Welcome to the Catalyst Podcast, brought to you by Chestnut Health Systems. I'm your host, Charles Epstein. Today's guest is Diana Kelly, a licensed clinical social worker, clinician, educator, and clinical director for the consulting and training team at the Hazelden Betty Ford Foundation, where she leads the development and implementation of national training and consultation initiatives for the ASAM Criteria Fourth Edition, including both the adult volume and the adolescence and transition age youth volume. Diana is an Army veteran with 12 years of service, during which she served as both a combat medical sergeant and a sexual assault response coordinator with over 15 years of clinical experience in substance use disorder treatment and recovery. Diana has worked extensively with military veterans and individuals involved in the justice system. She is especially passionate about supporting women veterans and advocating for inclusive, equitable, and holistic, person-centered approaches to care, particularly for historically underserved and minority populations. Diana Kelly, welcome.
Welcome. Thank you so much for having me. I'm really excited to be here.
Oh, delighted that you're able to find the time to do this. And you're calling in from where exactly?
I live in Indianapolis, Indiana. So I am in Indiana this morning.
Very nice. And what's the weather like there?
It's really actually quite beautiful this morning. It's sunny. It's around 80, which was lovely. We had a little bit of a heat wave last week, but yeah, weather is really nice today. It's a beautiful day in Indiana.
Excellent.
Yeah.
Excellent. Well, I figured I'd start out by giving you an opportunity to gloat.
Yeah.
Yes. I always try to find an opportunity very early on in the conversation for the guest to gloat. So there you go.
Yeah.
Anyway, again, thanks so much. Really do appreciate it. I need to ask you straight away, going from the service to working for an organization like Hazelden Betty Ford seems like a big change. What did you take from your 12 years in the service to your current role?
Yeah, that's a really good question. There was a little bit of so between my role in the military and the Army, I did take a lot of that experience and transitioned into working at the VA with veterans in Indianapolis. So I still felt somewhat connected to the military because that was my day-to-day work with people like me, with veterans. So it still felt really, really natural. I was around military folks all the time. I was around veterans. And then I transitioned into teaching at Indiana University. I still taught military courses, so I was really connected there. And then eventually came over to Hazelden Betty Ford, where really I don't work with a whole lot of folks in the military. But I will say, things that I have taken with me from my military career that transition really well are just some of the skills I learned at a really young age in the military. You know, if there's a goal, if there's a mission, I'm going to do it. I'm going to do it to the best of my ability. I'm going to show up. You know, the care I think I try to have for my team, for my colleagues, that was kind of instilled from the military. So I do see some of the skills and some of the things that have been with me in the military for a really long time come to life on a day-to-day basis in my work now. But yeah, it's quite the change from
Yes.
going to helping people medically, because a lot of my work was, again, being a medical sergeant, doing that kind of work, and then transitioning into helping people in a different way.
Yeah, again, I could see the differences being very stark, but I could see some of the commonalities. So, yes. For those of our listeners who are not familiar with ASAM, what exactly is it?
So ASAM, the American Society of Addiction Medicine, and that they are an organization. They truly are the authority or the standard in our field for how we do our work. So a lot of clinicians like myself, we would use the term ASAM kind of widely, right? If a patient was coming in and doing an assessment, we would say, we're doing an ASAM, because ASAM is also known for assessment standards. One of many is assessment standards. And a lot of clinicians like me who've done that work in assessments with patients, that's kind of how we use the word. But ASAM is an organization that truly does set the standard for our field. They're the authority for how we should be doing work with adults and adolescents in our field. They set the standard for assessments, for services we should provide, for, hours that programs should be doing intensive outpatient treatment, what kind of staff should be in those roles, what competencies they have. So really, they are kind of the national authority for how we should be doing work in the substance use disorder field. They do advocacy, they do policy. So they really are just the national substance use disorder kind of authority on how we should be doing the work in our field.
Ah, great.
Yeah.
So in your intro, I mentioned your work revolving around ASAM Criteria Fourth Edition.
Mhm.
So when was this released, and what about it is novel? What about it is new?
Oh, I love this question. So ASAM came out with a new volume of the ASAM Criteria Fourth Edition in 2023. Before that, it was their last volume was in 2013. And when we do this training, we pause and we ask people, when the last volume was published, it was 2013. What was happening in our world? What was going on in our landscape around that time? And I do some fun kind of interactive activities to kind of show people by playing songs from 2013 and just getting people back in that mind frame. But in 2013, we were experiencing as a country, that was the height of the opioid epidemic, right? So imagine this, the National Authority for Substance Use Treatment putting out a new book saying, hey, here's the standards for how we should be doing work in our field in the midst of the opioid epidemic. So fast forward to 2023, they have 10 years plus of experience of all that we've learned from the opioid epidemic that they put into this volume. And so when we started reading it and learning it, as a clinician, and I'm also a person with lived experience, I'm a person in active recovery myself. I read that book and I almost exhaled because I was like, oh my goodness, this is how we should be doing substance use disorder treatment in our field. It took everything that we've learned from the opioid epidemic, from our patients, from science and research, from practice wisdom, right? So the standards now include things like harm reduction, risk reduction, medications, holistic person-centered care. Because there was a time, Charles, in our field where if I came and I had a substance use disorder, and I also, had trauma, they would be like, you know what, Diana, go take care of your trauma and then come back to us
Mm.
when you're healed so we can treat your substance use disorder. No longer, right? ASAM is saying that is not the case. We need to treat these things at the same time. So this volume truly is the blueprint for how we want our field to evolve in the ways that we've learned best from all that we experienced from 2013 to now. So the standards are just updated with more of the research that we've learned, the importance of medications, the importance of meeting people where they are. And I think most clinicians have done this already, but having these standards, kind of quantified in a book saying, no, this is best practice. We're not going to say Diana's not ready for treatment. We're going to say, hey, Diana, are you ready for medication? Let's just start there. That's a best practice. So just seeing people put at the forefront, honoring their lived experience, honoring their humanity, it really is a phenomenal update that has the possibility of just changing our field in so many ways and how we treat people with substance use disorder and co-occurring conditions.
Is there a fixed interval that determines when you're going to be doing another edition? So in other words, 2023, is it going to be 2033,
Yeah, that's a good
or is it driven by
question.
situation? Because, these days in certain other areas, for instance, with the emergence of AI, things are changing rapidly in ways that have been unforeseen. So I wonder, again, is this a fixed interval, or is it based on, oh, gee, there are certain things in the field that are changing rapidly. We now need to investigate that and revisit.
Sure, sure. And there are people much smarter than I that work at ASAM. They have groups of people that take part in writing these books and writing these editions. Hazelden, we publish them, but they have so many experts that actually write the standards. And I don't know that it's a fixed interval. They have had intervals before 2013, but I think it has been on how the field evolves is when they determine when the next publication is going to come out. But I will say, and this kind of transitions into the adolescent volume, they've recognized so much with this fourth edition and how much our field has changed. To your point, they're like, we need a volume for adults. We need a volume for adolescents and this transitioned age youth. We also need a volume for those that are justice involved and in justice involved settings. And we also need a volume for behavioral addictions, right? So we're seeing this increase in gambling and, other behavioral addictions like gaming. And so they are making a volume specifically for that population. So I think,
Right.
again, to your point, as things evolve, as we learn more, ASAM is learning more, and they're really meeting the field where it's going. And I think they'll continue to do that.
Yeah. Yeah. Actually, you anticipated my next question, which is what does ASAM say about the unique treatment needs of adolescents and transition aged youth?
Yeah.
What essentially does that cover?
Yeah, that's a really great question. So in the version of 2013, the ASAM third edition, I can pull up my book because I have, of course, every every ASAM book just like right at my reach. There the standards for adolescents and adults were integrated. So there wasn't a lot that was said about the specific treatment needs of adolescents in the third edition. This new book, this new volume that got put out for adolescents and transition age youth is actually bigger than the adult version. And again, I think we've learned through science, through research, through brain development, or about brain development with adolescents. They're not just tiny adults. There's a lot of unique considerations that we have to think about when we're treating adolescents compared to treating adults. So we know, and I love, the brain development part of adolescent brains. Like, it's the gas before the brakes, right? So one of my colleagues here at Hazelden that I work with, she always says, Diana, adolescent brains aren't fully cooked, right? That's why they're making the decisions that they're making.
Right.
So when ASAM developed this book, they're saying, hey, there are a lot of different unique considerations when it comes to adolescents. One being like, they have adults in their lives, or many of them have adults in their lives. How are we integrating adults into their care? How are we making sure that they're safe, right? That adolescents are safe, that they have support, that they have structure at home, to avoid risky substance use. We also have to think about the language that we're using with adolescents. It's very different than the language that we're using with adults. Building trust and doing that in appropriate ways. Recognizing the potential for trauma with young folks and the emergence of co-occurring conditions with adolescents, presents in different ways than it does with adults. So yeah, ASAM suggests they have like a list of probably 8 different things that are, much different than working with adults. But a lot of it has to do, again, with brain development, age and stage, having appropriate interventions for adolescents compared to adults.
Yeah, some of the things that you mentioned, once you sort of set the stage and say that, yes, adolescents need to be treated separately. They're not just unformed adults, however you put it. Their brains don't fully form until a certain age, 24, 25. So some of the things you're saying about language, et cetera, make perfect intuitive sense. Is there anything among those things to the uninitiated that might strike that person as maybe counterintuitive, something I would not have thought about as far as calibrating my treatment or approach to adolescence?
Yeah, that's a really good question. The developmental considerations, this one, I think, and for my team, when we were thinking about it, the importance of prevention and early intervention. I think people know that, like, hey, prevention is really important. Early intervention is really important. But this volume really stresses that's so important. Like, that is so important. And I think of this just even in my own life and with people that I've interacted with. Again, I come from the DARE era, right? I don't remember what I ate for breakfast this morning, but that DARE song, right? The DARE song you learned in 5th grade or 6th grade, that sticks in my head. So that DARE song I remember. But there was a time I remember when adolescents would do adolescent things, maybe experiment with substances, or they were in, opportunities or situations where they were doing that. If they got caught, maybe they got into trouble, right? They got put in detention, and then that was it. Now ASAM specifically is talking about, we need to wrap around these kids when those things are happening. There was a statistic in the book, and I'd love to share it. And that's one of the first things I do in our training is I'm like, what percentage of adults with a substance use disorder, started, or at what age did they start using substances regularly, or what percentage of adults with a substance use disorder also struggled as kids? And it's like 80%, right? 80% of adolescents started using substances. It developed into a substance use disorder. So we know that adolescents, when they start using and they use earlier, the likelihood that they're going to develop a substance use disorder is very high. So the focus on prevention and early intervention, and not just, again, a 1 hour class or education, but this volume really is saying, hey, if we have a kid that's using substances and they have some other high risk factors, maybe there's a family history, maybe there's some genetic component, maybe there's some other impulsive behaviors, let's actually get them into treatment. Let's do some secondary prevention measures in like an outpatient treatment setting to get them the care they need to change their trajectory. I think that's one of the biggest things that I really appreciated about this volume, because again, I remember there was a time when if that were to happen, I would have just gotten into trouble. There wouldn't have been an adult in my corner or somebody else to say, hey, Diana, you got some things going on. You're engaging in some of these behaviors, and maybe we need to get you some help, as opposed to saying, hey, you know what? Detention, that's it. And let's see where you end up, kid. Now there's really a focus on direct service provision for adolescents that are at higher risk and using substances.
The updates all focus on quote unquote person-centered care. That's a term that's used a lot. People who are not familiar with conversations around person-centered care may say, well, wait a second, isn't all care person-centered? What does that mean exactly? So to that person, what would you say? What does person-centered care really mean? And what does it mean? Maybe it means something else in the updates. I don't know. But so I guess the question is twofold. What does it mean? And what are the implications for the new guidelines, if you will?
Yeah, I love this question. So, I think I talk about this all the time in my trainings. I tell clinicians and folks that are coming into our trainings, I was like, you've likely been doing this the majority of your career. ASAM's catching up with you by kind of codifying it into a book and saying it's best practice. Person-centered can mean a lot of different things. Because again, there was a time when people would come for treatment. Charles, let's say I came for treatment, and I had some anxiety about going to group, or I had some anxiety about engaging in, one-on-one treatment, but maybe I was ready to start taking medications for my opioid use disorder. There may have been a time where people said, you know what, Diana's not ready yet. Let's have her come back when she's ready. Right. And we don't have the luxury of doing that right anymore, I wouldn't say the luxury, that's a terrible word to use, but we can't do that with the substances that are in our communities, that are in our world right now, because if I were to come back some other time, it may be too late. Right. So now we meet people where they are. That's just one small example of being person-centered. It's saying, hey, Diana, you're not ready to go to group right now. You're not ready to do individual therapy, but you're ready to start on medications. Let me meet you where you are. Let's get those started and move forward from there. Right. Meeting people where they are and getting them what they need. That is one example of being person-centered. But also another example is, hey, Diana, you the best. What if we recommended a residential treatment and I have kids? A lot of my veterans, they would rather leave their spouse than leave their dog. And that doesn't mean that they weren't ready. That means that there's truly some barriers to them engaging in substance use disorder treatment. It doesn't mean that they're not ready. It means that, hey, there are some real barriers. Let's look at this person holistically and see if I can't work with them to navigate some of these barriers, to meet them where they are, to get them in that care and in that treatment, or at the very least, let's talk about some other options to keep them healthy, safe, and alive. Also, there might be somebody that wants a clinician that looks like them, or that speaks their same language, or that has gender specific treatment options. So we're hearing people and what they want, what may work for them, where they're going to feel safe, where they're going to feel comfortable, and we're working with them to get them that care that they need. Because imagine, Charles, if I was like, "Hey, you're going to start treatment tomorrow in this place. You know nobody, you know nothing about it." Um, and it's not something that you're comfortable with. Are you going to do well in that treatment program? Probably not. But if you
Right.
had some buy-in and you had some, some buy-in into where you were going and what your treatment was going to look like and who your provider was, you might have more success. So again, person-centered, it means a lot of different things, but I really think it is recognizing that people are the experts on their own lives and trying to get them the care that they need to keep them healthy, safe, and alive in a way that's going to work for them.
Excellent. Well stated. Anytime this comes up in conversation, I'm just going to point them to this exact timestamp in
Yeah.
this conversation. So we'll have that covered. So thank you.
Yeah.
Um, the new edition talks about integrating families
Mhm.
into care. This can't be a new idea,
Right.
integrating families into care. So how does it talk about this in the new edition?
Yeah, and again, I don't think it is new. Every person that works with adolescents and young adults likely works with their families for a variety of reasons. Oftentimes, families are this, the way that treatment's getting paid for, the insurance is coming, or the insurance is being used to pay for that. In some states, and every state is different. We're learning is, the rules for consent or assent, or how people can get treatment. A lot of times, families are absolutely involved in it, but I think the research has been presented that when families do well, kids do well. A lot of times and honestly, we don't do this well in adult treatment as well. We're really working with the patient one-on-one. And I don't think a lot of people have had exposure to how beneficial it is to engage a significant other in their care and in their treatment. And so with adolescents, it's even more pronounced. There's terminology in this book called again, they keep saying when kids do well, or when families do well, kids do well, or when kids do well, families do well. It kind of goes both ways. But this idea of having a supportive other in your life, even if it's not nuclear family. So it could be an aunt, an uncle. It could be anybody in your family who the child, the adolescent feels is supportive, to just kind of be in their corner and support them during this time. It could also be coaches, teachers, but having somebody else there involved in their treatment and involved in their care is really just paramount, and it's talked about throughout this volume. Um, ASAM also talks about specific evidence-based practices that are used for families and family approaches, and if the kid is struggling and if there's some things going on at home, how can we wrap around that family and provide the care and provide that services, not just for the adolescent but also for the family. So this whole volume is family through and through, which again, it was different from the third edition. Third edition had, standards that were embedded. There was some information about, family throughout, but this volume really hones in on the importance of family engagement throughout the entire process.
What in this new edition is new about the topic of prevention? What is this new edition? How does it talk to prevention?
Oh,
What's
and
new?
yeah, this one again is so near and dear to my heart, just for my own experience being a 15-year-old, and again, getting into trouble a lot. I'll just be honest about that, getting into trouble a lot, and really not having people kind of look at it a little bit closer and be like, hey, what's going on in this kid's life, right? Like there's some behaviors that are happening, but and instead of now, saying like, this is a bad kid. Like maybe this is a kid that just needs some help. So prevention is talked about in this volume really in a secondary and tertiary prevention, specifically, not so much early intervention or primary prevention. ASAM is saying, hey, primary prevention can happen anywhere. We're really looking at secondary prevention for adolescents that are using substances, and that have some other risk factors. So we want to get them plugged into treatment, plugged into care soon. And the idea behind this, Charles, and I love this idea and ASAM's vision for this, and they're so right. If we got a 15-year-old into treatment and into care when they were using substances at that young of an age, and we expose them to some skills, right? Some refusal skills, some developmentally appropriate interventions that young of an age, we really have the opportunity to change, like to have a generational impact on their life. And I think that's pretty important, for clinicians, like understanding just the brain development. And if you have the opportunity to impact a 15-year-old, teach them some skills they can carry on with them the rest of their lives, how that could impact them when they're young adults, how that could impact their kids and their kids' kids. Like, I think that's so powerful. And ASAM really does do a great job of, again, pointing to the fact that let's get kids and adolescents early when they're engaging in these behaviors to be able to have that impact generationally in the future. So now it really is about, identifying that sooner. So looking at risk factors, looking at protective factors, and getting them plugged into the appropriate level of care. And in this volume, there's actually a whole separate track for secondary prevention. So if I was a patient and I don't have a substance use disorder diagnosis, but I am drinking with friends on weekends, maybe there is a genetic predisposition on, one of my parents' side. Maybe some of my parents aren't so super supportive. Maybe they're engaging in some substance use. That might mean that I would need treatment at a, 1.5 outpatient level of care or a 2.1 intensive outpatient level of care. So again, ASAM is just really explicit in having completely different criteria for those adolescents to reach them quicker and sooner, to really change the trajectory of their lives, which I think is powerful.
All of these guidelines presuppose that these services are accessible and the people who need them can access them. Does the new edition speak to access to care and various levels of access across the country, particularly where access is limited?
They do. Yeah, they do in a lot of ways. ASAM recognizes like these standards are visionary. And even when we do these trainings with folks across the country, sometimes I have to come with like my army armored vest on, because people, when we talk about, hey, this is the new continuum, these are the new levels of care, people are like, we don't have that. And I'm like, I know. This
Right.
is ASAM's vision for how our field should be set up. Should be is kind of the key word, right? That, hey, we need to have the lowest level of care possible, which is a level, 1.0, all the way to level 4, and all these levels in between so that people don't fall through the cracks. But we know, right? The people that come into my trainings know, I know, living in Indiana, that the resources available here aren't the same in Iowa and aren't the same in California. So we really try to tell our training participants at the beginning, this is visionary, right? ASAM's continuum of care, what they're hoping is visionary, but a lot of things have to happen for these things to align. We need funding in the right places. We need policies to change. So this is as much of a macro issue, and it trickles down all the way to the service provider level, because we recognize not all of these levels of care are currently available in the ways that ASAM is saying, hey, here's the standard for this. But as a clinician in rural Indiana, I may be like, yeah, that's nice, but that's not available to me. So ASAM does, in their book say that. They're like, we know that these levels of care aren't available right now. This is the vision for how we want our care system to align, but everybody has to align. again, meaning payers and government and policy. So, and again, they're big advocates for that. But what I think is nice about both volumes is even though these things aren't available right now, there's a blueprint. That's a start, is there's a blueprint for the vision of how we want substance use disorder treatment to look in our field. That's a start, and it's a vision that keeps people at the forefront and really allows for people to get the care that they need. So yes, it'll take time, and yes, all of these services aren't available now. And even ASAM says, like, hey, we recognize that due to access and location and funding, a lot of these won't be available. So you can combine, services, and you should coordinate with other people and other agencies in your community. And yes, use telehealth when you can to fill some of these gaps. There's a part in our training that I love to do, especially when we have people from all over the country come into our trainings. We do a discussion for about 7 minutes where I'm like, hey, so one of the updates is this Dimension 6, which is meeting people where they are and identifying, what some of their barriers to engaging in treatment are. So some of the barriers are transportation, some of them are childcare, some of them are, just access to these levels, and hearing people from all over the country share some of these amazing grassroots organizations that have come together to help support people is always just really endearing and shows the power, of people just trying to help people. So it's always a good time to hear how people pull together to help people in their communities.
Yes. If the fifth edition were coming out in 6 months, what would you like to see in it?
Oh, that's such a good question. If the fifth edition was coming out, what would I like to see in it? Ooh, I don't know about a fifth edition, and I'm not ready for it. I'm still learning the fourth edition. But you know what would be really interesting? So they've had these different volumes. They've had the volumes for adults. Now they have adolescents, transition age youth. They're coming out with justice involved. They're be coming out with behavioral addictions. I would love to see something for military veterans. I think that's a really different or a really unique population. And for those that are still active duty, that looks a little bit different. So I would love for there to be a special volume on military and veteran population, but that's maybe just some of my bias.
I think, no, it sounds like a very, very good, worthwhile idea. I think we're going to have to bring that up to whoever
Yeah.
decides these things.
Yeah. That's such a good question, though. I never thought about that. What would I want in it? And I'll be honest, like just the fourth edition in itself, because as a clinician and a person, with lived experience, I've lived the things that have happened since 2013 with the opioid epidemic. Over 1 million people have lost their lives due to the opioid epidemic. And when I was learning and reading this fourth edition, both for adults and adolescents, it was almost like I said, I deep exhaled and was like, oh my goodness, like we took all of that, all of what we've learned, and we put it into a book that can truly help people. So again, fourth edition, the updates I think are phenomenal and are exactly what clinicians, payers, stakeholders across the country need to be, to reach people. So I don't know. I mean, I can't wait for it to come out because I'll probably be just as excited about it. But yeah, I can't think of anything where I'm like, they really missed the boat on this fourth edition
Right.
here.
Right.
Yeah.
Okay. Well, I think it was a worthwhile question to at least get the
Yeah,
synapses going.
no, it's a great question. It's a great question.
Anyway, Diana, again, really do appreciate you joining me for this great conversation today. And I really enjoyed learning about all your work and taking this deep dive into ASAM and the fourth edition.
Thank you, Charles. It was a pleasure. What a wonderful wonderful way to spend a Tuesday morning. You've been a pleasure. Thank you so much for having me.
Thank you. Today, I spoke with Diana Kelly, a licensed clinical social worker, clinician, educator, and clinical director for the consulting and training team at the Hazelton Betty Ford Foundation. Diana joined me today from her headquarters in Indianapolis, Indiana. This is Charles Epstein for the Catalyst Podcast, brought to you by Chestnut Health Systems. For more, visit www.chestnut.org. Thanks for listening. See you soon.